the information. So if you worry about the next one. I don't think
Good morning, everyone. Thank you for being here. I'd like to call to order this meeting of the Public Health Council on August 23rd, 2016. Thank you all for being here. My name is Dr. Bharel, Commissioner of the Massachusetts Department of Public Health. Just a reminder, this is a public meeting and is being recorded. I would like to let the members know that there has been a change in the docket and we will not be bringing the base date determination of need to the council this morning. We will bring this to you at a future date. Also, I'd like to introduce two new members to the council. Lisette Blondette comes to us as the Director of the Massachusetts Association of Community Health Workers and will fill the corresponding seat. Michael Regas, Chief of Staff to Secretary Urena of the Department of Veterans Affairs, is joining us to fill the veteran seat on the council. We look forward to both new members bringing their knowledge and expertise to the council. Welcome to both of you. Thank you. As always, I'd like to start by highlighting some of the great work that happens here at the Department of Public Health. In July, I had the privilege of seeing some of our work up close as I visited 2 sober homes in Lynn. Starting in September, only voluntarily certified sober homes will be able to accept referrals from state-funded programs, including the court system. This is a major milestone in ensuring that those in the early stages of recovery get the supportive environment that they need, including those with unstable housing options. I want to thank the Bureau of Substance Abuse Services and specifically Cheryl Kennedy Perez for her ongoing efforts to see this work through. I also had the privilege of touring several programs in Worcester, including the Ronald McDonald Mobile Clinic, the UMass Memorial Emergency Department, and the AIDS Project Worcester, which is home to one of our newest needle exchange programs. At the Needle Exchange Program, I was able to meet many clients and heard compelling stories of their struggles and their striving to recover and to be healthy. I also want to thank Dr. Bernstein, where are you, Dr. Bernstein, and his team for a tour of their new Faster Paths to Treatment program at Boston Medical Center. This is a new opiate urgent care center that is providing access to acute treatment services and the full continuum of care for treatment of individuals with substance use disorder. When I was there, I met several case managers and counselors that had been there since the 90s when I trained there and are truly dedicated to fighting this opiate epidemic. I'm constantly amazed by the work being done around the state to address the opiate epidemic. Another tool in fighting the opiate epidemic is our prescription monitoring program. I'm excited to announce the successful launch and implementation of the Massachusetts Prescription Awareness Tool, otherwise known as MassPat. This is the new online prescription monitoring program, which we just launched yesterday. Over the past 6 weeks, the department has reached out to prescribers and pharmacists across the Commonwealth and partnered with key stakeholders to encourage them to register in the new system. And over 32,000 users have registered for MassPat and can now search their patient's prescriptive history over the past year. Some features of this new system include enhanced functionality through a user-friendly interface with faster access to reports. As of yesterday, access to data for providers was being accessed within 1.5 seconds. There's also the ability to conduct interstate data sharing, and as of now, we can query prescription records from Rhode Island, Connecticut, and Vermont, and we're working to finalize partnerships with New York, and we'll quickly add other states after that. Congratulations to Eric Sheehan and the entire team who have worked tirelessly over the past 15 months to get the system up and running. I'd like to take a few minutes to mention to the council some staff and departmental changes at the Department of Public Health. I'd like to welcome Nora Mann, to the department as our new Director of the Determination of Need program. Nora came to us from the Office of the Attorney General, where she spent 9 years, most recently as Assistant Attorney General and Deputy Division Chief of the Nonprofit Organizations and Public Charities Division. We will hear from her a bit later as she presents on the Determination of Need regulations. Going forward, Nora will be presenting the DON projects that come before Council. Please join me in welcoming Nora. And thank you to Mike Sinicola and the team for keeping this important work moving forward as we search for the director. Congratulations also to Benjamin Wood. Is Ben here? Ben Wood? He's in the back. Congratulations to Ben from the Bureau of Community Health and Prevention, who was promoted to Manager of Community Health Planning and Engagement. Ben plays a crucial role working with communities on the community health benefits of the Determination of Need program. A big thank you to Ben as he served in an acting role for this position for the past year. And finally, I'd like to welcome Tom Lyons back to DPH. Where's Tom? Tom left the department in 2009 after serving for 2 years as the Director of Communications. He's a 20-year veteran of public health. He most recently ran his own company which specialized in health communications and public relations for nonprofits, and is now returning as our Communications Director. Welcome to Tom. And I'm pleased to announce that effective August 15th, 2016, the Bureau of Healthcare Safety and Quality became 2 separate bureaus: the Bureau of Healthcare Safety and Quality and the Bureau of Health Professional Licensure. This strategic restructuring will more effectively promote public health, enhance employee engagement, and improve customer service. It will help us better align our work with the customers we serve. Facilities and institutions, primarily under the Bureau of Healthcare Safety and Quality umbrella, and individual practitioners under the Bureau of Health Professionals and Licensures. Please join me in congratulating Eric Sheehan, who is now the Bureau Director for the new reorganized Bureau of Healthcare Safety and Quality, and Jim Lavery, who has been named the Bureau Director for the new Bureau of Health Professional Licensures. Council members, any questions or comments? Okay, thank you. We'll move on to the docket now. Our first item on the agenda is to ask the members to vote to accept the minutes from July 13th, 2016. Before we vote, do any members have any changes? Okay, could I have a motion to accept? Dr. Woodward, could I have a second? Dr. Cunningham, thank you. All in favor?
Aye.
Any opposed? Any abstain? Is that a Michael abstain? The minutes are approved. At this time, I would like to ask Mike Sinicola, Interim Deputy Director of Healthcare Quality and Safety, and Rebecca Rodman, Deputy General Counsel, to present on all 3 Kindred Hospital transfers of ownership to Curahealth, and then the council will vote on each separately. I would also ask the following individuals from Curahealth to stand by: Chester Crouch, CEO, Ken McGee, COO, and Emily Crutcher, Legal Counsel. We'll call you up after. Thank you. Mike?
Thank you, Commissioner. Good morning, members of the Public Health Council. My name is, Commissioner mentioned, is Mike Sinicola. I'm Interim Deputy Director of the three sites for your consideration include Kindred Hospital, Boston, and Brighton, Massachusetts. Application number 4-3C49. Kindred Hospital, North Shore, Peabody, Massachusetts. Application number 6-3C50.
Just can't hear you if you
Sorry.
don't speak a little closer.
Sure. Is that better? And finally, Kindred Hospital Northeast in Stoughton, Massachusetts. Application number 5-3C51. It is important for the council to make note of the fact that each of these three determination of need applications require separate and independent votes for approval, but I will be presenting all three in one presentation here. Curahealth is a limited liability corporation formed earlier this year. Should the council approve the transfer of ownership, the applicant and its affiliates will own and manage 12 long-term care hospitals in a number of states, including the three here in Massachusetts. Please note that none of the transfers of ownership include capital expenditure. Both the Brighton facility with 59 beds and the Peabody facility with 50 beds are currently licensed acute care hospitals operating as long-term acute hospitals. Both provide a full range of inpatient services for patients with medically complex conditions requiring continued chronic care and who need extended inpatient hospitalization with an average length of stay of 25 days or more. The Stoughton facility is a licensed non-acute hospital which operates 47 chronic care beds and 41 inpatient psychiatric beds. This hospital also provides a full range of inpatient services for patients with medically complex conditions and who need extended inpatient hospitalization with an average length of stay also of 25 days or more. Based upon review of the three determination of need applications, staff finds that each of the three applications independently satisfy the transfer of ownership standards set forth within the determination of need regulations, including local control, Medicaid access, compliance with applicable laws, and licensure. The board members will be responsible for decisions at Curahealth concerning borrowings, changes of service, capital and operating budgets, and determination of need filings. The applicant has consulted with the Executive Office of Health and Human Services regarding Medicaid recipient access to medical services. The change in ownership as it relates to the Stoughton facility does not involve any change regarding access to the hospital services, since its status with Mass Health will remain unchanged. However, because neither the Brighton nor Peabody facilities are currently Medicaid certified, staff recommends several conditions of approval for each, stipulating the applicant work with Mass Health in an effort to seek certification to enroll as a Mass Health provider. Please see pages 2 and 3 of the staff summary for your review. Staff has determined that neither the applicant nor any of its affiliates nor individuals representing the applicant is currently excluded from participation in Medicare, Medicaid, or other federal health care programs. Staff also notes that as part of the licensure process, the Division of Healthcare Facility Licensure and Certification will perform a suitability review for this transaction and must issue a notice of suitability before it can issue a license to Curahealth following the change of ownership. A public hearing was held on July 19, 2016 at the Department of Public Health in Boston, Massachusetts. The hearing was attended by approximately 8 individuals, one of whom, the Chief Executive Officer of Curahealth, testified in support of this application. There was no opposition, no opposition to the change of ownership. After careful analysis and based upon the applicant's compliance with the determination of need standards of approval, staff recommends approval of the transfer of ownership for each of these three determination of need applications with the conditions included within the staff summary for your review. This concludes the determination of need presentation. Chester Crouch, Chief Executive Officer presenting Curahealth, is here today and is prepared to answer any questions you may have. Additionally, Rebecca and myself will answer any questions you may have. Thank you, Commissioner.
Thank you, Mike. For the record, Ms. Dougherty has joined us. Thank you. Good morning. Questions for Mike on the DOI? Mr. Lansing?
This actually may be more
that requires a licensure change with the facility licensure, they will too.
Does the applicant believe that they will be qualified? Do they see any obstacles in order
I can't answer that for the applicant, I'd have to defer it to the applicant.
We can have the applicant come up in a minute. Are there any other questions for the program before we do that? Dr. Bernstein?
Just a clarification, the health equity issues are also completely separate from your determination of that's still what the requirements. It seems like there's about 20 different conditions.
Yes, the health equity, those are conditions that are, they're conditions of this approval.
And they're not in place in the present situation, they haven't complied with them, or they need to comply with them, or what's the status of those?
This sometimes happens if the Office of Health Equity isn't able to get out prior to DON approval. So the agreement in that case is that they will go out and that the applicant will comply with whatever the office says. It's not uncommon that they're not able to get out in time. So that's why there's a general expectation.
Thank you.
Dr. Rupert, did you have something? No. Anybody else? Any questions for the program? Okay, so can we make some room for Curahealth staff who are here today to come up?
Thank you, Commissioner.
You could all introduce yourself, I appreciate it, thank you.
Sure, good morning, I'm Chester Crouch, I'm the CEO of Curahealth. I'm joined by Emily Kretschmer, who's counsel for Curahealth. And then Kim McGee is in the back of the room, including him, he's our chief operating officer. So, in terms of the question on Mass Health, one of the three locations currently is in Mass Health. And so it's hard for us to know all the nuances because we've not been operating these hospitals. Kindred has been the operator. But just in my thinking, and that's part of our agreement in the language of we'll work with the state and all different parties on assessing the need. If there's a need and we can provide that service, we definitely will. And so to have one of the locations currently be a Mass Health, it wouldn't surprise me if the other two did come into Mass Health. But obviously that's a decision that Mass Health would have to make as well.
Has that exploration process started yet, or are you ready for this?
We were waiting on this approval.
Any other questions for the applicant? Dr. Woodward?
So you're a relatively new corporation, it appears, and it says you will have 12 facilities, 3 in Massachusetts. What other states are you operating in, and were those Kindred facilities also, or
Yes.
how did you put your corporation together?
Yes, the Curahealth entity was formed specifically for the purchase of the 12 Kindred LTACs. The other states that they're in, there's 3 hospitals in Arizona, there are 2 in Oklahoma. Kids chuckling because I always get mixed up on this, but 2 in Oklahoma, 1 in Tennessee, 1 in Louisiana, and 2 in Pennsylvania, as well as the 3 here in Boston, in Massachusetts.
So you're saying it was formed in essence to take over Kindred?
Well, it was formed for the purpose of acquiring these 12 hospitals. And
So tell us about that transition from Kindred to this entity. Was
Sure.
Kindred involved in setting up this corporation?
no, sir, they're separate, completely separate entities in the transaction. So Curahealth is led by myself. I'm a physical therapist, have 20 plus years of experience in the industry in healthcare and post-acute care. I have a master's in business administration as well. Kim McGee is our chief operating officer. Kim is a nurse, has an MBA, and has a PhD in organizational behavior as well. We both have a collective close to 50 years of post-acute care experience in healthcare. And most recently, we were part of Reliant Hospital Partners, which purchased the Braintree New England Rehab Hospitals here in January of 2014. We were part of that company and that acquisition, so we do have experience in working in Massachusetts. We think we understand some of the nuances here. And so we're obviously committed to the care and the delivery system that is in place here and continue to further that. So we do have some experience here.
So in essence, you formed to take over these Kindred facilities. Did Kindred approach you, or you had been aware or working with Kindred and aware they were interested in selling these 12 facilities?
Yeah, there's always conversations that go on between companies or potential buyers, and those kind of conversations come about, and then it becomes a product a company wanting to sell, another company wanting to buy, and if you can make the transaction work, then it works. And I will say this, that Kindred did a really good job in the transaction to allow Curahealth to be successful. There are some regulatory changes going on in the LTAC space. Kindred is, divesting of some of its assets and some of its non-core markets, as they say. So they were really, there's been a very good transition here and a very good transition plan. In fact, we have about a 6-month agreement on transitioning all the services. So we should have a very good transition here that's good for the employees, good for patients, and allows these facilities to continue to be successful.
Any other, Mr. Lansing?
Who is the most senior member of your management team that is or will be resident in Massachusetts?
The local CEOs are all residents are all residents of Massachusetts, and they've all been in those facilities for a number of years. Bob is here as well, who's the market leader for Kindred in these 3 hospitals, and he'll continue on with Curahealth as well.
Are any of your the 3 current facilities have any organized labor units operating?
We do have union in one of the locations. I believe it's nursing and some of the ancillary services. And can you recall which?
North Shore.
It's Boston North Shore.
And has that union expressed any concerns and support for this transition?
They've not expressed any concerns. In fact, we were in all the hospitals in the last 2 weeks doing town hall meetings and meeting with leadership teams and meeting with them as well. So we've not had any concerns or issues. And in fact, we're actually excited about working with them.
Yeah, and you expect to continue on that contract when you take over ownership?
Yes, sir. Yes, sir.
Do you anticipate any job loss as part of this?
No, all the employees will come over. All the leadership teams will come over. In fact, we've been very impressed with the makeup of the personnel and the leadership teams as well. So we're excited about putting kind of our model in place to give them a little bit more of a focus on post-acute care. And so we think with the personnel and leadership we have there, with somewhat of our management style, that we can be very successful there.
Any other questions from council?
I have
Mr. Lansing?
one question for staff. I note here that you and staff may request a second report 6 months after the first report relative to seeking and securing a Mass Health certification. If that report is forthcoming, I would ask that we should report it out to the council. And if in the view of staff, the effort to receive certification was not successful, and there's a sense that there was not a full faith effort, is there any recourse relative to this approval?
To answer the first question, absolutely, we would bring that back to the committee, yes. As far as the second question is concerned, the current regulation will allow for me to present to you potential revocation.
Any other questions from council? Ms. Wanda?
I would prefer, and I being new with these, I'm not sure how to frame this question, but regarding the Mass Health certification, I'd much rather see the recommendation from the staff be the applicant agrees to work with Mass Health or to comply with Mass Health certification, so that it's not up to if Mass Health agrees, but you're committed to making sure that you are Mass Health certified.
Dr. Rodman will take this question.
We can't, if they aren't eligible, if they can't do it, we can't hinge this on this, in part because they can't actually complete the application, the enrollment, until they have been licensed, until we've approved this and have found suitability. So this is the best way to make sure that the good faith effort will occur while still not overstepping.
Yes, Ms. Dougherty?
Kindred, in the past, recent past, has developed a home care company, Lodge. I'm wondering what the relationship between you and those home cares
Well, Curahealth will be focused on just purely its 12 hospitals, the LTAC hospitals. I know Kindred's model has been to become their model has been to proliferate the other segments of post-acute care. So we will work with all the other post-acute segments, whether that's IRFs or home cares or assisted livings or all the other hospitals and providers will work within the marketplace to make sure that patients are placed appropriately and that they're in the right spot for them. But our focus will be purely these 3 hospitals.
Okay, I guess my question is, when we're talking about ACOs and arrangements where there's a continuum of care expectation, how is that going to work for you? How are you going to?
Well, we would, I'm going to use the term partner with other post-acute providers to be able to be involved in that continuum.
Any other questions from the council? Okay, with that, I'm gonna ask the council, remember, we have to do this as 3 votes, so if you can, come along with me. So, I'd like to ask for a motion to accept the staff recommendation for approval of the Kindred Hospital Boston request for transfer of ownership to Curahealth Boston LLC. Can I have a motion? Mr. Lancikos, can I have a second? Who was that, sorry? Ms. Dougherty, thank you. All approve?
Aye.
Any opposed? Any abstain? Okay, so, that is approved. Moving to the second one, I'd like to ask for a motion to accept the staff recommendation for approval of the Kindred Hospital Boston North Shore Peabody request for transfer of ownership to Curahealth Boston. Can I have a motion? Mr. Lancikos, can I have a second? Dr. Cunningham, all approve? Any opposed? Any abstain? Okay, please note for the record that Michael Rodriguez has abstained. Okay, with that, we are approved the Kindred Hospital Boston North Shore request for transfer of ownership to Curahealth. Thirdly, I'd like to ask for a motion to accept the staff recommendation for approval of the Kindred Hospital Northeast Stoughton request for transfer of ownership to Curahealth. Can I have a motion, please? Okay, Mr. Lancikos. Can I have a second, please? Dr. Cunningham. All approved? Any opposed? Any abstained? Mr. Rodriguez abstained. Okay, with that, we have approved the staff recommendation for approval of Kindred Health Northeast Stoughton request for transfer of ownership to Curahealth Boston. Thank you, Curahealth team.
Thank you.
Thank you, Commissioner.
Now we will move to preliminary regulations. At this time, I'd like to invite Nora Mann, Director of the Determination of Need Program, Jay Yeoman, Special Advisor to the Commissioner, Tom Mangan, Policy Analyst, Ben Wood, Manager of Community Health Planning and Engagement, and Rebecca Rodman, Deputy General Counsel, to present on the proposed regulatory amendments to 105 CMR 100 Determination of Need. Nora? And a reminder to the presenters, it's loud in here with the AC, if you can speak into the microphone. And to council members, when you ask questions, if you could speak directly into the mics. Thank you.
Thank you, Commissioner Bharel and members of the Public Health Council. My name is Nora Mann, and I'm honored to serve as the new Director of the Determination of Need Program and have an opportunity to give you today the first look at a proposed revision of the DOH the DTH DOM regs before it is released for public hearing and comment. At the very highest level, we're looking at a paradigm shift to a streamlined and retooled process that puts public health at the core of the DOM process. DOM represents a significant executive branch tool that, because it sits within the Department of Public Health, can be realigned and infused with public health principles in order to advance the state's health care reform and public health goals. Doing so will allow the Department of Public Health to create incentives and disincentives to drive positive shifts in market behavior. Public health principles are vital to systems being able to take on risk in the future. And that's why we're proposing a set of historical overview of DON. We'll talk a little bit about the proposed regulation itself. We'll go through some next steps, and then hopefully I'll be able to answer questions, and if not, my colleagues certainly will. So some history. DON as a concept, and I believe these slides are in your packet. To the extent I can use this, I will help point to what I'm talking about. So as a concept, it was created by the business community. It was developed initially by Eastman Kodak in partnership with Blue Cross Blue Shield as an effective tool to help understand cost increases, especially those that were not tied to increases in quality care, and for those folks to have some degree of control over the costs. Ultimately, 49 states enacted DON laws covering more or fewer aspects of healthcare. With respect to our law, based on a comprehensive analysis of DON programs throughout the U.S. that was done in Missouri a few years ago, the Massachusetts law is actually the least expansive DON in all of the New England states. As of today, 14 states have actually repealed their DON laws entirely, and that has had suboptimal results, specifically contributing to escalating healthcare costs. Here are 3 examples. In 1996, Ohio dramatically narrowed the scope of its DON reviews, and in the first 4 years following deregulation saw a dramatic and unrestrained growth, including a 600% increase in ambulatory surgery centers. In 2000, the state of Michigan, facing possible repeal, the state's big 3 automakers got together and completed business analyses to compare healthcare costs for their employees who were in DON-regulated states and those who were not. All 3 companies found that healthcare costs were lower and the quality was generally improved in DON-regulated states. And our neighbors in Connecticut in 2016 were looking at a dramatic increase in overall market consolidation. They placed a moratorium on mergers and acquisitions, and leadership there has called for significant enhancements in the DON laws. So here in Massachusetts, our program was established by the legislature in 1971. When looking at where to place DON, the legislature was mindful of the mission of the Department of Public Health: to prevent illness, to assure access, to promote wellness, and health equity for all the people of the Commonwealth. The mission has historically been interpreted to direct DPH to play an active role in measuring population health and wellness, identifying and understanding the social determinants of health, as well as in policy design of the delivery system. Consistent with this interpretation, the legislature put DON here in DPH. It was intended to provide state government with a regulatory mechanism to ensure that healthcare resources were allocated in such a way that healthcare services would be available to everyone in Massachusetts at the lowest reasonable aggregate cost. However, DON has not evolved in coordination with significant market shifts and responding healthcare reform efforts. So here's the problem. It's been outpaced by a rapidly evolving healthcare market, and currently DON is not aligned with the DPH core mission. When it was instituted in 1971, healthcare was largely provided in standalone, nonprofit hospitals or small group practices, and reimbursement was cost-based and set by a rate-setting commission. In that model, DON was designed to prevent overspending on healthcare. As a result, the goal was to prevent saturation through the non-duplication of services. After Chapter 224 in health reform, healthcare is now comprised of complex health systems that closely control patient referral patterns with a desire to take on increased risk. In this world, the objective of DON has been the non-duplication of services rather than incentivizing competition on the basis of value. An unintended result is that DPH is limited in its ability to incentivize value-based market competition, that is, competition on the basis of outcomes and price among providers, which would in turn encourage the development of services that result in better health outcomes for fewer dollars spent, and perhaps most importantly, accurately reflect the needs of members of the community. The disconnect between the current DON regs and the modern healthcare market has resulted in two challenges. One is that DON has been unable to successfully realign its incentives and disincentives to advance public health policy. The other challenge has been with respect to our ability to support providers who desire to take on more risk. At the same time, and notwithstanding these very real challenges, and because of the tremendous opportunity for the healthcare commonwealth, DON represents a significant executive branch tool that can be realigned to positively advance state public health reform and public health goals. Our plan will be to help reestablish EPH's role and vision. We believe we are uniquely situated to do so in a way that supports industry. So the question is, where can government, specifically EPH and DON, play the most meaningful role? To figure out, let's look here at what traditional health planning before Chapter 224 was, and then compare that with the role of health systems and where DON can and we believe should play a role. So in DON of the 1970s, Mrs. Smith here, her world, leveraged traditional health planning, which was about measuring services available in a particular geographic area and making determinations as to whether those levels satisfied patient needs. Did Mrs. Smith live close enough to the services that she needed to be healthy? In an era of health systems transformation in which systems are advocated to take on significant risk or even total risk, those systems remind us that they're doing health planning, and that's great. However, if these same systems want to truly manage risk and reduce clinical costs, the systems need to apply public health principles in their decision making. So here you see a potential ACO world in which a system argues that Mrs. Smith has access to all the services she needs to be healthy because the system makes all of those services available regardless of geographic proximity. I want to point out, though, that neither of these two worlds actually exists today, but neither is actually in conflict with one another. We call it false choice. Healthcare today requires looking at social determinants of health and creating situations for consumers in which the healthy decision can most easily be the default decision. Thus, even when systems take on true risk, BPH is uniquely situated to create incentives for population health management that will allow health systems to play an active role in addressing those social determinants of health. DON should be about creating a connection among traditional clinical intervention, innovative clinical prevention, community-wide prevention, implementing interventions that reach whole communities. To bridge these two roles that overlap in the Venn diagram, DON needs to look at that those interlocking issues, that overlap. On the left, the question is, why is the proposed project needed by your patients? How will it increase accessibility and access and affordability? And how specifically will this project improve the health outcomes of your patient? In short, how does the project improve the health of the system's members? On the right is the question of state health priorities. How will this new project also respond to the needs of the local community? When further developed through an open and inclusive process, health priorities will create an opportunity to place at the fore important issues that are critical to improving community health. However, this can only happen with a coordinated approach to population health. No single provider can do it all. Rather, all of the stakeholders have to work together. Health priorities are a way to harness significant resources across systems and across the state. They will be developed with stakeholder input, health disparities data, and designed to improve the health of Massachusetts overall. These health priorities initially include tackling population health and using tools that will help the health system to take on risk by decreasing the financial burden. Under the proposed scheme, the questions will become both, how does the health system respond to patient needs in a public health way? And ultimately, how does the proposed project advance the shared goals of all systems as and of the state to coordinate investments in population health across the Commonwealth's communities. Balancing and overseeing the response to those two questions reflects DPH's regulatory mission. In doing this, high-value, community-based providers will be critical. So how do we build a DON that reflects this vision? There are 7 steps. I'm going to outline each one in some detail. They include simplification and streamlining, modernization to reflect the modern healthcare market and realign with core principles of DPH, an increase in objectivity and transparency, creating true benchmarking and accountability of DON projects, leveraging community health initiatives toward state health priorities, reframing reviews to non-innovative equipment and technologies, and aligning incentives with community conflict sustainability. So I'll go through each one of these in a little bit more detail. Today, before simplification and streamlining, today the regulation is over 80 pages long, it's administratively burdensome, has a complex layout, and is drafted in ways that are often unclear. It includes multiple processes for different types of projects without a clear purpose, and lacks coordination with licensure plan reviews, which ultimately costs applicants time and money. And because it lacks a delineation between expensive but necessary deferred maintenance and true market expansions, the result often disadvantages smaller hospitals with older physical plans. We propose 1. Coordination of processes and the removal of repetition, so that the proposed new reg is 40 pages long. It's a decrease of 57%. The proposed new regulation also allows for the coordination of DON with licensure plan review. It implements a rolling application process, all of which will save significant time and dollars. We propose the creation of a new conservation projects definition with an expedited review process, creating that delineation between deferred maintenance projects that may meet the expenditure minimum and thus would trigger a DON, and truly new, expanded, or modernized services and facilities for which DON is designed. In addition to that simplification and streamlining, we propose to realign DON with modern public health principles. The goal today is non-duplication of services. As we developed this proposal, it was with an eye instead to creating incentives for value-based market competition. That is care where cost and quality are aligned and driven by public health. DON today can use individual facilities, not systems, resulting in a process that really is not reflective of today's healthcare market. The old system, the one that relied on Mrs. Smith's geographic health planning system, relied on geographic space rather than systems-based patient needs. As proposed, the provider organization or the parent company is going to be our applicant, while reframing the DON questions to truly examine the provider organization's patient needs. The current scheme doesn't require Medicaid participation because we believe that access is critical. This is an important element of reform and will ensure the care and well-being of the Commonwealth's most vulnerable residents. Right now, we ask the wrong question on transfer ownership by asking, does this community need a hospital? Communities may be better served if we can account for real public health implications of increased consolidation. Those implications were shown in testimony provided by Professor Lemore Daphne. She's a recognized authority on FPC issues, and at the 2015 HPC cost trends hearing, her data showed that increased market power within state lines often, if not always, significantly contributes to increased costs, increased price variation, and on balance, decreases patient access and health outcomes. Our proposal amends DON's objective to better align with existing statute and to reframe DON within the context of modern prioritizing the public health focus, the development of innovative health delivery methods, population health strategy,